So yes, I'm going to start this session. Please be reminded that this session is being recorded. Okay. So good afternoon, ladies and gentlemen. I would like to welcome you to this parallel session that will focus on dementia diagnosis and disclosure. Together with the rest of the organizing committee, I would like to thank the speakers who accepted to participate in this session and share with us their thoughts on this topic, which I'm pretty sure you will find very, very interesting. I would also like to extend my warm welcome to individuals with dementia who also have joined us in this virtual meeting. With regards to presenting myself, I am Charles Scerri. I'm the chairperson of the Malta Dementia Society and vice chair of Alzheimer Europe. I am a graduate from the University of Dundee in Scotland and currently an academic member of staff at the University of Malta with special research interest in the medical and social aspects of Alzheimer's disease and other dementias. Now, going back to the title of this session, there is no doubt that although we have made significant progress in timely diagnosis of dementia, more work needs to be done. We all agree on this. If we take a glance of what is happening across Europe, we notice that in some countries, arriving to a diagnosis from the time the symptoms appear or show still takes significantly long, in some cases exceeding even 2.5 years. When diagnosis eventually happens, a good percentage of individuals with dementia are not informed of this. We will have 4 speakers who will discuss this topic during this session. I would appreciate if you mute your microphone. I guess it's already been done by our technology moderator. All presentations, I have to say, all presentations have been co-authored, and the list of the co-authors is provided in the conference website. So each presentation will take approximately 15 minutes, and the speakers will take questions at the very end. So please, if you have any question, write it down on the chat platform on Zoom so that I can pinpoint it to the speakers when the presentations are finished. So let's start with our first presentation. It's going to be delivered by Janne. Professor Papma is an assistant professor at the Erasmus Medical Center and Alzheimer Center in Rotterdam, the Netherlands. Janne will be talking about the diagnostic and treatment challenges of behavior and psychological symptoms in Alzheimer's disease, a qualitative study in memory and clinical practice. To you, the virtual floor, Janne.
Yes, you can hear me now, right?
Yes, please.
Yes, okay. Thank you very much for this introduction. Today I will present on diagnostic and treatment challenges of behavioral and psychological symptoms in Alzheimer's disease from the perspective of the memory clinic. Behavioral and psychological symptoms of dementia are acknowledged to be early symptoms of Alzheimer's disease, even the first presenting symptoms. And these symptoms are more often considered to be an integral part of Alzheimer's disease. And they relate, for example, to a reduced quality of life, caregiver burden, higher caregiver burden, and earlier institutionalization. So these are very important symptoms to take into account. Therefore, also, the early recognition of these symptoms, for example, already at the diagnostic stage, may have a positive effect on early support, psychoeducation, and treatment options, for example, psychosocial treatment options. However, diagnostics and management of BPSD in AD in the memory clinic seems to be quite fragmented. And in order to establish this earlier recognition, we will need to know more about the opinions, attitudes, and procedures of memory clinic physicians when it comes to BPSD in AD. Our project aims were to examine the experiences and attitudes and procedures of memory clinic physicians with regard to the recognition and treatment of BPSD in AD patients visiting the memory clinics in the Netherlands. And we wanted to do that in order to identify opportunities for improving early recognition and management of these symptoms in Alzheimer's disease. Therefore, we held semi-structured interviews with memory clinic physicians of both academic and general hospitals in the Netherlands. And we interviewed 7 neurologists and 5 geriatricians with an average experience in the field ranging between 4 and 30 years. And the interviews were recorded and transcribed verbatim. And thematic coding was performed by 2 researchers, followed by a consensus meeting. And we looked for themes regarding the recognition and treatment of BPSD and AD in the memory clinic. Well, when it comes to the recognition of BPSD in the memory clinic, we identified 4 themes in the qualitative data. The prevalence of BPSD in early AD, the assessment of BPSD in AD, the role of the memory clinic setting, and the scope of the memory clinic setting. And I will discuss these all with you. First of all, looking at the prevalence of BPSD in the early stages of AD, there were neurologists and geriatricians who reported to encounter BPSD in early AD often in the memory clinic, but others that indicated that these symptoms either arrive late in the disease or just don't stand out. And furthermore, 2 neurologists specifically related BPSD to hearing a diagnosis of AD. For example, often after half a year after the diagnosis, BPSD has improved as the diagnosis has sunken in. The assessment of behavioral and psychological symptoms in the memory clinic turned out to be quite differently approached. For example, 1 neurologist performs the intake together with a psychiatric nurse and actively diagnoses these symptoms, while another neurologist explained to try and have a somewhat more systematic approach in a conversation, as when you just run by all these symptoms, this does not give you the information you need. So he really wants to incorporate it in a discussion or in a conversation. Others do not actively ask for these symptoms, such as, I do not actively ask for these symptoms, therefore they are not discussed. It was indicated that the memory clinic is not the best setting to either diagnose or manage these symptoms, as they occur in the home situation. For example, the advantage of a case manager is that you see the situation at home. People that come to the outpatient clinic are all dressed up, and that makes it more difficult. However, another neurologist actually tells us that the advantage of having both the patient and the caregiver in the room is that you can obtain what is happening at home. The diagnostics and management of BPSD in AD in the memory clinic were also questioned. So is it actually that these symptoms are within the scope of the memory clinic? One geriatrician even mentioned a philosophical dilemma in which you treat a patient, and when the patient has no complaints, why would you then give attention to these symptoms? On the other hand, he acknowledges that the caregivers who then have problems with these symptoms are quite essential. Others wondered whether the recognition is part of the memory clinic, while others claim that it's very important and not something you can just leave up to the GP, as they may not recognize these kind of problems. Well, considering the treatment of BPSD and AD in a memory clinic setting, there were 3 themes emerging from the data, and these were the pharmacological treatment, the non-pharmacological treatment, and psychoeducation. A pharmacological approach was actually not preferred as a first-line treatment approach for BPSD in early AD by the majority of the memory clinic physicians, so by geriatricians or by neurologists. They were skeptical about the effectivity of pharmacological treatments. Like one of the geriatricians says, a pharmacological approach does not really work anyway. You can try Haldol or Memantine, and if it works, you're lucky. Others acknowledge the side effects of pharmacological treatment, and delusions and hallucinations were were often treated with medication. So these were seen as problematic behaviors that had to be treated with a pharmacological approach. Non-pharmacological options were used by some of the memory clinic physicians. For example, one neurologist who describes it as the doctor as a medicine and explained a person-centered approach. Other physicians placed non-pharmacological treatment actually outside of the memory clinic, for example, with a case manager or at the daycare centers. And one neurologist thought of cognitive behavioral therapy as a potential non-pharmacological approach, though not something that he was experienced with. Psychoeducation was something that was used and valued by many of the geriatricians and neurologists. For example, explaining the symptoms helps both the caregiver and the patient. The patient feels better understood and the caregiver has more insight into what the disease encompasses. Or, because you see, the better the caregiver is informed, the more the behavioral problems decline, because the caregiver no longer continuously tries to fight it. Finally, we also asked the physicians how to care for these kind of symptoms, so behavioral and psychological symptoms in Alzheimer's disease would look like in an ideal world. And answers ranged from structurally diagnosing and discussing BPSD during the first patient visit in the memory clinic, so acknowledging that we should pay more attention to these symptoms already in the diagnostic stage, to having a specialized team or extra personnel to diagnose and manage these symptoms. For example, a nurse practitioner that visits patients at home as an extension of the memory clinic care, or ideally, we would like to have a specialized team with a GP, case manager, and a geriatrician. In conclusion, we found large differences when it comes to the early recognition or diagnosis of BPSD and AD in the memory clinic in the Netherlands. And this was associated with knowledge upon the prevalence and the impact of BPSD in the early stages of the disease, but also on the way that these symptoms were assessed. So some of the physicians didn't even ask for these symptoms, while others asked for it thoroughly. And also upon opinions upon the scope of the memory clinic care. So does this belong to memory clinic care or doesn't it? Treatment of BPSD and AD in the memory clinic was rather diverse. Some physicians performed pharmacological treatment of problematic behavior and only did that. But also some physicians performed this person-centered, non-pharmacological approach in which they really looked for the causes for these kind of behaviors and discussed this thoroughly with the patient and also evaluated afterwards whether some approaches that were non-pharmacological worked out. And in an ideal world, and they were or sometimes were not involved, so that wasn't entirely clear. Well, I would like to thank our great team and specifically Willem Eikelboom, who is the PhD on this project and does great work. And I would furthermore like to acknowledge all the participating neurologists and geriatricians for participating in this research. And I would like to thank you for your attention, and you can find me on Twitter. Okay, thank you very much.
So let's pass on to the next presentation. And it is a presentation that is actually being delivered by two speakers, I have to say, Sean Mackell and Kevin Quaid from the Dementia Research Advisory Team. Now, Sean lives in Papma in Ireland. Sean is living with Alzheimer disease and is an active member of the Dementia Research Advisory Team and chair of the Irish Dementia Working Group. With respect to Kevin Quaid, Kevin lives in Limerick, in Ireland as well. Kevin is living with Lewy body dementia. He is an active member of the Dementia Research Advisory Team and Irish Dementia Working Group. He is also a member of the European Working Group of People with Dementia. And Sean and Kevin will be talking to us about What a diagnosis of dementia tell me? A call for more research into dementia subtypes.
Good afternoon, everybody. My name is Sean Mackell. I am 67 years old and I'm a former General Secretary of a trade union. I used to do magic tricks for my grandchildren. I was known as Magic Papa Sean. I could make balloons disappear and sweets would magically arrive in my hands, much to the delight of 3-year-olds. Then the dementia chief thief came into my life and started to steal words and on some days sentences from me. As a trade union leader, I would wow a packed room. Oratory was my friend. In time, there will be no oratory from me at all, just silence. So thank you for the opportunity to speak to you today. I really appreciate it. Kevin?
Thanks, Sean. I'm Kevin Quaid from County Limerick in Ireland. I am a son, a husband, a father, a stepfather, a grandfather, a godfather, an uncle, a good friend. I was diagnosed with Parkinson's first, and I too have dementia, and I am a new member of the European Working Group. Sean and I are both members of the Dementia Research Advisory Team. The Dementia Research Advisory Team is a group of people living with dementia and carers and supporters who are involved in dementia-related research as co-researchers. This is known as patient-public involvement, or as I like to call it, person-public involvement. The only time I'm a patient is when I'm in hospital. Every other time I am a person. Sean and I are delighted to be here to represent all members of the team. Sean?
We and our colleagues influence, advise and work with researchers across Ireland to improve the quality and relevance of research. We are supported by the Alzheimer's Society of Ireland to influence change and ensure that the lived experience is considered in designing and implementing research. We believe that people living with dementia and their care partners should be given greater opportunities to be involved in the design and process of research. People living with direct experience of dementia can make valuable contributions to the design and direction of dementia research projects. Another important aspect of person-public involvement is research priorities, i.e. setting the research question. We are here today to set a research question, and we hope that you will be inspired to try and answer it. Several months ago, our group met to discuss this conference and planned out what we want to talk about. There were a couple of ideas in the mix, but this topic was head and shoulders above the rest from the perspective of both people with dementia and their families. I have a diagnosis of dementia. I was diagnosed 2 years ago at the age of 65. And as a result of my dementia, I struggle with my memory and finding the right words. Kevin?
Thanks, Sean. I too have a diagnosis with dementia, but my memory is fine. My dementia means that I struggle most with night terrors, fears, and hallucinations. If our colleagues of the Dementia Research Advisory Team were here, they would list different challenges. Even though we all have dementia, our experiences are completely different. I have Lewy body dementia, and Sean has Alzheimer's disease. We both have dementia, but our experiences are so vastly different. We see two key challenges. Firstly, people are not being diagnosed with dementia. Instead, they are being told they have memory problems or doting, which is a word used here in Ireland. People with dementia are often told that they're just getting older, where in fact they have a disease that requires medical care. Even though getting a dementia diagnosis is horrible, it can be a sense of relief because we know deep down that something is wrong. A diagnosis entitles us to answers, to much needed services and supports for both us and our families, but memory problems does not. I want to share some statistics with you. In 2017, a study was done in an acute hospital in Ireland. It found that more than 1/3 of patients over 70 had dementia, but 74% of these did not have a previous documented diagnosis of dementia. Another study in 2015 looked at 5 acute hospitals in Ireland. It found that only 36% of patients over 70 were recorded as having dementia at the time of admission. You can learn more about this by reading the report of the second Irish National Audit of Dementia Care in acute hospitals. Sean?
The second issue for us was that people who receive a diagnosis of dementia, they are often not told what the type is. Kevin and I are some of the lucky ones. We know what type of dementia we have, but even Alzheimer's disease can be so varied. There are 400 types of dementia. I am fighting to learn more about my diagnosis, but it's really hard to get answers. We need research to equip healthcare professionals with tools to make diagnosis and to give us the best chance to live well with dementia. When you think about other diseases like cancer, the difference is vast. People are given specific information about their type of cancer, and a plan is outlined at diagnosis, even in cases that can't be treated. Dementia is a very different disease, but we cannot accept poorer quality healthcare. It's incredibly difficult to diagnose dementia. Health and social care professionals are overworked and memory clinics are oversubscribed. We are calling upon the research community to continue to expand their research into brain disease and different types of dementia, so that people and their families can benefit from much needed clarity around their diagnosis. This can lead to better care, treatment, understanding, and ultimately a better life for the person receiving the diagnosis and their family. Kevin?
If you're listening today and thinking about doing research in this area, we want to work with you. We want to help you. So let's take on this fight together. You can reach us through the Alzheimer Society of Ireland. Just contact Laura at research@alzheimers.ie, and we hope to hear from you soon. Thanks everyone for listening.
So thank you very much, Sean and Quaid, for that. I have to say important presentation, because the voice of people with dementia needs to be constantly heard. They need to be involved in all the things that we do with respect to dementia, and they can only join the chorus of other people here who are putting the comments in the chat platforms, congratulating you and on your contribution to the dementia cause. Obviously, we need to do much more, but the importance of the voice of people with dementia cannot be underestimated. So thanks again on behalf of all the participants in this conference, not only in this session, but also in this conference as well. Do we have Jean Ambrose on the platform as yet?
No, he's not there yet.
He's not there yet. So we have quite some time for questions, and we do have some questions. All right. So let's start with a question from Wendy Perry to, let me find it first, to Janne. And the question was, do you think that the resistance to directly address the topic of distressed behavior or behavior changes is related to the physician's knowledge level or comfort with psychosocial interventions.
Yes, I do definitely think that. Yeah. Yeah, because also, for example, mentioning cognitive behavioral therapy, well, that can be quite extensive and not something that you would just do as a neurologist, for example. But that really shows that it might be that they don't know what kind of approach they can take in these kind of symptoms. For example, you can just start with asking when something happens, who was there, and then you can just discuss with the patient and the caregiver, well, maybe we can try to prevent such a situation and do it a bit different and see whether that helps in, I don't know, aggressive symptoms or these kind of symptoms. So it can already be really small. It does not have to be a complete therapy, but yeah. So the answers that some of the physicians give actually seem that they don't really get that. So yeah, I think so.
Do you think that the terminology behavioral and psychosocial symptoms of dementia is the right terminology to use rather than challenging behavior, for example? Because we all have behavioral and psychological symptoms of dementia, not of dementia, but every now and then we get though aggressive, every now and then anxious as well. So do you think that the terminology is good enough?
You have a lot of different terminologies. I just decided to use this terminology for this presentation because it's used in the scientific literature a lot. But for example, we also use neuropsychiatric symptoms, unexplained behaviors. There are a lot of different terminologies for the same thing, and that is that that we need some term to indicate that in dementia there are behavioral behaviors that occur more often. For example, agitation, apathy, aggression, these kind of symptoms, and that they are part of the disease. And I think that's actually really important. That we need to know that it's not just, for example, in Alzheimer's disease, it's not just only memory problems. There can be more symptoms, and in every person it's actually different. But it's really important to take into account these kind of problems, since these are the symptoms that play a role in the home situation. And these kind of symptoms, they are very important for the caregiver to know how to deal with, for example.
I'm saying this because a good number of people with dementia find the terminology of behavior and psychological symptoms of dementia a little bit offensive. You know, terminology is always difficult anyway, but they find it a little bit offensive to them.
Yeah, we can also use
sort of a labeling.
Behavior, I can understand. I just use it because it's used a lot in scientific literature. So for me, it doesn't. It can be other terminology as well, as long as you know what I'm referring to.
I have another question to you, actually. In the study that you're part of, actually, did you get any feedback regarding non-pharmacological interventions? Are specialists actually trained in this aspect?
No, not really, no. And that's also something that I'm going to look into more, because there was also a question about that. We're going to look at experience and also at the way they were educated. But for example, in the especially in the persons that have a lot of experience, so are a bit older, they did not have any education in non-pharmacological treatment of these kind of symptoms, actually. And also, they question whether that belongs to the geriatrician or the neurologist. But I think when you do notice these kind of symptoms, you would want to do something with it. Wasn't it to refer it, then maybe to already give some psychoeducation about that it belongs actually to to the disease, can belong to the disease, is part of the disease, and not that people are think that the thing that they are struggling with is special. That's not the case. A lot of people with, for example, Alzheimer's disease have are struggling with apathy or with aggression now and then. Yeah.
I have a question from Nina Balakova, who is asking your opinion, our opinion actually, because it's to everyone. Is BPSD more often encountered at the start of the illness or later?
Well, it's actually both. There's more knowledge now about that. Definitely, these symptoms are also part of the early disease stages, whereas previously everyone thought, no, that's something that only happens at the end stages of dementia. But now it's really clear that it's already, it can be even the first symptoms. For example, apathy can be a first symptom actually of, for example, Alzheimer's disease. And in other types of dementia, because Sean actually did this, and Kevin made this great speech about it. And my research is focused on Alzheimer's disease, but for example, in frontotemporal dementia, the behavioral symptoms are the most important symptoms in the beginning, in the behavioral variants, and also in so in different kind of types of dementia, you have different types of symptoms that mainly present themselves with. But I think it's really important to just know that these symptoms are already present at the beginning, but also at the end stage, and there are more often certain symptoms present at the in the beginning. For example, more depression, apathy is quite stable, but these kind of symptoms also fluctuate over the disease stages, across the disease stages. So, yeah. So it's not that in the beginning it's more and at the end it's more. It's across the disease.
Yeah, it varies from one individual to another as well. And I find this topic extremely important, not only to the medical community, I have to say, but also to informal caregivers as well, because it is the behavioral aspect that puts more pressure. I meet a lot of people, I meet a lot of caregivers who tell me it's not the cognitive part that really concerns me, but the behavioral part. I don't know how to act, how I can help my relative with respect to the behavioral issues as a result of the, and it's the usually it's the main cause for institutionalization. At least here in Malta, the main cause of institutionalization is the problems with behavior, not problems with cognition, but problems with behavior. And unfortunately, we don't focus that much on this, especially with caregivers. We don't have enough maybe information to give to these individuals. Okay, maybe we will reach the medical profession, the nursing profession as well, but not so much in informal caregivers, I have to say.
Yeah, and that's why we really would, why we're focusing now on the diagnostic stage, and we're hoping to actually, have a better recognition in the early stages, and already have, for example, the physicians there telling something to the patient and the caregiver about these kind of symptoms, and then referring them to, more information about it. Yeah, so that early on already people know about these kind of symptoms and have some, tools. Yeah, tools not the good word for it, but have some knowledge about how to deal with these kind of symptoms.
So thank you very much, Jim, for that lovely presentation, I have to say. I have a question for Stina from Lewis Killen. So the question is, the difficulty recruiting is interesting, given that this would be an important point and chance for reflection for people who are concerned about their memory. Why do you think some people were not interested to take part? And do you think this in itself is a finding?
Thank you for that question, Lewis. Like I say, I did find that quite noteworthy in terms of the numbers of, needing to screen 180 people to get 63 people in the study, and 65 people obviously said that they are not, they don't wish to take part. And I do think that is quite noteworthy for similar sorts of research. Different reasons. I think it can go down to how much people know about research and how much value people see in taking part in research, how we present research to potential participants. Like here in the UK, there's been a lot of discussions around sort of the participant information sheets, for example, which sometimes sort of ethics boards might want to be longer than maybe the researchers would intend. So it's such a practical point, but if you present somebody with a 10-page document to see if they would like to take part in research, then that might well put somebody off. So it's worth thinking about these practicalities as well. Another thing, where the research takes place. So based on my sample, just about everybody preferred a home visit rather than coming into the research facility. So, if it's all possible to have that sort of flexibility with the research setting. Obviously now with COVID, like I said in my presentation, we are not allowed to do home visits here because we can't mix households in the UK. Some research is moving to remote mode, so doing visits over Zoom, but that in itself comes with challenges and access to the sort of technology for people as well. So I think it is quite interesting the kind of proportions of how many people are approached and how many people end up in research, and it really raises questions of how accessible we make research for people.
Thanks. I have a question for you. Actually, I have two. So we all agree not all people with mild cognitive impairment develop dementia, right? What was the reaction of participants in getting disclosure of MCI? What did they ask for? Any particular information?
Well,
because obviously they get worried. They all think that they will eventually get dementia, but the truth is that yes, some of them will, but some of them don't.
Yeah, well, that absolutely hits the nail on the head for this study. Varied reactions. I would say from one end of the spectrum, we've got people who might be delighted that they were told they've got something that they refer to as mild cognitive impairment as opposed to dementia, because people might have been worried that they've got some memory problems, perhaps they've got dementia, whereas you've got other people who were perhaps hoping to be told that this is just part of normal aging, so kind of hoping to be discharged, whereas they were informed that this looks like something that we refer to as mild cognitive impairment. So that initial kind of perception, what people themselves think that might be going on, seems to really be a moderator to the reaction subsequently.
Yeah. And another question, did you take into account what type of medication participants were taking at the time of the study, knowing that there are a number of drugs, a significant number of drugs, I have to say, that can impair cognition? Yes, I did. Yeah, I've taken note of the medical history and any concurrent medications. So that's why I showed in one of the slides that there were a number of people who were, I refer to as pre-screen failures. So that was 34 people. So these were people who weren't suitable sometimes for those occasions, that the memory complaints and impairment was actually due to other reasons. So they were excluded from the study. Yeah, I think that is a very important aspect. We find a lot of people who complain about their memories, and then when we look deeper, we find that they are on a drug regimen that unfortunately